First question we had is regarding integration of the results of this test with your EMR. What means you have for processing or saving the test results and incorporating them into your medical record?
We load them currently into the patient chart. We are a healogics clinic, so it goes into the actual wound assessment right now. So that will be a permanent part of their medical record. For the vascular surgeons to see them a little bit more quickly and efficiently, we load those pictures into Epic. That's our home EMR, so they can reference them without having to kind of find them within our progress notes.
So they all easily upload and coordinate into any EMR system that you have, the pictures of what you really care. And then for the interpretation part, I have templates built for the positive, negative, and then can add in the specifics for each patient on what those numbers are and what we want to do. So it takes in all moments to get it in and to load up your assessment.
Okay, that sounds easy enough. Can this technology be used and billed using the T code in a physician's office currently?
There are multiple codes. Right now we use 2 codes within our clinic. It's the actual obtaining the image and then the read of the image. But there are other T codes. The NIRS company we work with have a great resource, but there are currently 4 T codes that can be applied with obtaining the NIRS images, yes. And one is in a physician's office.
You spoke of a number of cases regarding limb preservation. Have you noticed a decrease in amputations when you're integrating NIRS into workup?
Yes, and that's the whole point. And that's why I want everybody to ultimately someday have one of these cameras as part of any type of wound care or limb salvage program. Because again, I can identify a patient that has compromised flow that's critical before it's manifest into their skin. So I know that they have limb critical ischemia or that a surgical site's going to dehiss before it dehisses. And so then I can be more aggressive in my intervention, not just wait, because at this point you think, well, let's give it some time. It's looking okay today. Come back in a week. Well, a week later, it's necrotic and it's dehisced, and then there's early gangrene and there might be osteomyelitis and all these things that could have been avoided if you could have objectively seen there's a problem here. Let's do whatever intervention as aggressively as we can. So whether that's hyperbarics or get them back to vascular to talk about, is there anything else you can do here and avoid the major amputations. That's all we're looking for, is how can we avoid you having to have a below knee or worse amputation.
And we've had patients we've sent for vascular. We found we're low on their SpO2 on NIRS image. We've sent them. They've had a revascularization, and then they're chronic patients of ours, so they're here for a while, and then we re-image them, and they have that increase, and then we re-image them a couple weeks later, and or a couple months, and they're decreased again. We'll send them back to see their vascular surgeon, and they find that they clotted off one of their stents. So it's not just the initial, it's the ongoing, the trend of those patients, especially when they are some of your more complex populations that you say, okay, well, what am I missing? Okay, let's re-image them and see where they're at. We could take that one piece off the table and focus, and then really get focused on what we need to do. Well, we have found that in a couple of patients where they, need to go on to have either, FemPop or additional interventions in order to gain adequate flow.
Dr. Forbes, you had made the point that the NIRS imaging gives you an earlier warning sign when tissue is losing oxygenation, earlier than you would see clinically by just examining the patient. Can you give the audience a sense of how much time that's buying you? What's the lag period between when you see the decline in circulation on NIRS and when you see tissue loss?
That's a great question. I want to go back to this. So I think because this is perfect. This is such a common thing any podiatrist will have a similar story if you've been doing it for more than a week, probably. These diabetic patients, you know, they're microvascularly compromised because maybe their A1C is high, maybe they have a history of smoking, and they're borderline compliant, but you have a real medical issue that you have to address this. You can't just do nothing and say, well, you're non-compliant, so I'm not going to do it. You got to do something. So to get to the question, how early can you see significant changes with the camera versus seeing it in your clinic? And that is such a nuanced question because it's a little bit different for everybody. And I can only give you anecdotal evidence there because part of the limiter there is I don't see people more than once a week. So if I could see them every single day and then, you know, catch it and say, okay, that was the 24-hour difference or the 48-hour difference. So I only have the 1 week to know. So my answer to that's going to be 1 week because I'm going to see it right after surgery. They're going to come to me and say, okay, sometimes a podiatrist will just send them over and say, I've done the surgery, go back to you, please get that healed. I'll do a NIRS image right after surgery, and I might get a picture just like this on the right where you got really good blood flow except right in that peri-surgical area. If I will see him back in a week, that's already going to be bad, but I know now, and I'm going to get the ball rolling and be as aggressive as I can. This patient, I want him urgently in the hyperbaric chamber. So wait a week, none of that might happen because that second toe is going to start showing some changes and eventually become gangrenous, and your outcome is going to be totally different in this patient getting the picture now versus 1 week later.
You had made the point earlier that the device is particularly valuable in the setting where you're working closely with vascular. Do you find that you have the occasion often to send the NIRS scans to the vascular surgeon to impress upon them the urgency of the particular case?
Yes, and that's one of our major uses for it, and that's one of the major selling points is instead of calling a vascular surgeon and say, I might feel a pulse, but it's pretty weak, and the cap refill is a little bit delayed, and they've got all these other comorbidities, and I'm concerned about them. Well, they get that same phone call probably 20 times a day from primary care offices and from the surgery or from inpatient hospital where they were admitted for congestive heart failure, and they're just concerned. Well, this is more than concern. With this picture, I have objective data to say, this isn't somebody that I need you to work up or screen. This is a patient that I've already done that, and I can tell you right now they need an intervention. And as there's some trust built with that, and they've seen the benefits and the accuracy of this camera, there's a trust to say, great, put him on the schedule, and I'm going to see him this week, see him early next week, and not wait.
We live in a data-driven world. There's no substitute for objective data to make your point.
Amen.
I'd say most of our patients, I wish I had a percentage, but say we send 5 patients to vascular a month, I would say about four of those 5 patients are receiving some kind of intervention or have a history of needing an intervention and need further vascular surgeries or what have you. So really that time, like Dr. Forbes touched on, that time wasted is not there because we already have kind of that data, that proof showing, okay, this patient probably will need further workup, arterial Doppler and possibly the OR time.
Can you give us a sense of the cost of this, what it costs to purchase this device or to have it in your clinic or your office setting, and your sense of what the most appropriate settings are where most of these devices have been employed?
Can you do the first part?
Okay. The cost, I would, if you are very interested, I would, highly recommend you reaching out to some of the one NIRS company. And I don't want to give a
come on.
Yeah.
What did our camera cost?
When we purchased it, it was $40,000.
Okay.
And we use it We have about 6 to 8 consults per day. We use it about 6 to 8 per time. That's if it's an appropriate patient. So knee below, multiple views on every patient. So we use it every day and quite often. So it is, for us, it's well worth its weight in gold. It has helped streamline our lower leg assessment, streamline our cardiovascular process and referrals. So for us, it was a piece of equipment that is irreplaceable now. Nurses are very well acquainted with it, with our process, and they obtain those images before the provider even sees them.
No, but he went there. We got to talk about money.
I know. Okay.
What percent? Okay, so it's November 2022.
Yeah.
What percentage of those are we getting reimbursed for?
Reimbursement is getting better. I will say that. What we're probably seeing 80% or is being reimbursed right now of our snapshots. Other ones, they are either we are working those denials and then we will be reimbursed from that, and we have great resources for that as well. That's kind of where we're sitting. However, because it's a new piece of technology, more and more insurance companies are becoming aware of them, and CMS is also being worked with to get those new, more specific codes and to have that better reimbursement. So the reimbursement is there, and it's increasingly improving since we had implemented it in March of 21.
Okay, and before I answer that last part of it, the question, I'm putting you on the spot, totally.
Okay.
I know. We don't have the numbers in front of us.
No.
What's your guess? How many times do I have to use this camera before I pay for it? 100 times? 1,000 times?
Let's say 100.
100 times.
100 times.
And I'm using it 6 to 8 times a day.
Yeah.
And I say yes.
Yeah.
I think we should get
It's
one.
like it's paid for already.
And if you're looking just at that, but you also have to think about your referrals to your other service lines this has kind of started, that is more effective and efficient. The time it takes for the patient, the cost for the patient, that in itself, especially with the service lines, I mean, you're including where, Dr. Forbes has even said this, we would, patients palpable, cap refill, refill is there, they're okay. So we'll treat them for a few weeks. This is pre-NIRS, and all of a sudden, okay, well, what are we missing? And we send them for our trail study, and then we find that they have monophasic flow. However, upon your assessment, everything looks good. This has helped streamline that. So I think the cost of care for the patient, cost burden for the patient, cost burden for the hospital, I think it has paid for itself, yes.
To answer the last part of your question, where is this appropriate? This is fantastic if you do inpatient rounds and you're getting a consult and you think, okay, do I do debridement? Is wound care appropriate here? Or if you're a podiatrist, do I do surgery on this patient, or do we need more information first? So especially as a podiatrist, I'd have this camera in my hand for every inpatient consult, and I take a picture and say, okay, they have that adequate circulation for healing, let's schedule surgery. Versus, I think we need to get vascular surgery involved before I'm comfortable determining an amputation level on this patient. So outpatient podiatry, inpatient podiatry, if you have wound care in your area, great, that's where it probably belongs. But if not, if you're just a limb salvage vascular department, great. Mm-hmm. That will help keep your surgeons doing surgical procedures versus doing the screening stuff on their own, where they're having to get the arterial Doppler and all the non-surgical stuff that they don't want to be doing.
Yeah, we also use it on our compromised flap, so like plastic surgeons or ENTs that do radical necks. We saw that one gentleman with the ear. Those are great places to implement that, this technology as well.
You made the point that it's cash flow positive, which makes the most sense in busy practices. But because this is such a visual medium, I'm thinking that it makes a lot of sense for growing practices that want to market their services and can show that they're using this advanced technology, which gives you objective data, where other practices just have subjective data, or maybe are limited to ABIs or techniques like that. And there's actually a question that came in. Do you continue to complete ABIs in the clinic since starting this technology in the office? But you just made the point that the technology is portable and you bring it to the clinic and the hospital, yes?
Yep. The camera's small, probably about that big, couple pounds. We house it in one of the cabinets locked up at night, take it out in the morning. It can go from room to room, easily cleanable, no, not an issue. And you can go in and out of rooms with no issue. I do want to touch on that, Mark. You kind of touched on marketing. With Healogics, we do market quite a bit, and this is kind of with this technology, we have marketed that to our community, saying, we have this resource and it's a really great resource, and our healing outcomes and our comprehensive heal rate, our amputation rates, heal rates have gone up, amputation rates have gone down with the usage of this technology. So that is, I think, something people should know, that you can market this to your community, your hospital community, your organization, to kind of shine a light on wound care and limb preservation programs.
And to be honest, we have actually probably kept that smaller than we could have, only because we know you take this information to your referral source, all your primary care docs, and say, look what we can do. We can instantly tell you if your patient has blood flow. They're going to want it, and they're going to send every single patient to you instead of doing the vascular workup. And if you're trying to drum business, there it is, instant busy clinic. If you're already busy, you got to be a little bit careful that you're not advertising it too much, because I think it's going to be a very popular technology. Everybody's going to want to know, does my patient have enough blood flow? Am I sending them to the right place? Do they need to go to vascular? Do they need to go to surgery? Do they need to go to wound care? I don't even know. So it's a great tool then to take to those primary care docs and say, this is what we offer you, and we can tell you instantly on your patients, and we will then triage them and get them to where they need to be if it's not us.
But then,
yeah. I would look forward to walking around the hospital or the clinic with this device and running into a doc that's involved in this patient's care and just showing him the picture and the numbers. How cool is that?
We've done that even with administrators. It's an easy way to get your administration excited too, because then we'll come by and I'll take a picture of your hand. Look at this. Look at the perfusion in your hand. I can see all of it instantly. And they light up and they say, this is amazing technology. How cool is this? We got to let all of our doctors know that you have this. And so it's a double-edged sword there, but this is a no-brainer technology. It's a game-changing technology. It's going to make your life easier as a provider to get people where they need to be. And everybody involved in the care is going to be more efficient in their care, instead of having to spend time and money and run the patient around town trying to get appropriate workup.